Hello and welcome to the Super High Yield Anesthesia Podcast, the second edition. This is your host, Scott, the anesthesia resident. Thanks for tuning in to the Super High Yield Anesthesia Podcast. This is Scott, and I'm very excited to be back doing actual educational stuff for you guys. I hope you had a chance to listen to my past two episodes, basically on the residency experience. So the most recent one, we caught up with Drs. Kenneth Wynn and Boe Su, and one before that, we kind of talked to Dr. Hoseclaw and Dr. Bahat regarding having kids during residency and the fellowship process. So today we are going to kick off the acute pain and regional anesthesia series. So I have a few episodes lined up for each of these topics, and it's going to be pretty much like an introduction to these fields. And then if you're doing like a rotation in acute pain, or doing a rotation in regional, or if you just want to learn this stuff for boards, that's what I'm going to try to really emphasize that on. Keep it high yield so that you're able to not only for practical uses, but also for board purposes. Okay, so so this first one, it's going to be kind of nitty-gritty details on pain stuff. So this episode's going to be on an anatomy and physiology of pain signaling, and the next one's going to be even more of a doozy, as we're doing neurochemistry of somatosensory and pain processing, so even more nitty-gritty details of pain signaling process. But after that, it's going to be a little bit more fun, I hope. Basically, we're going to talk about different drugs that are used to treat pain, and eventually, by the end of this series, you should be able to, think of different ways you can treat pain and come up with a multimodal pain regimen, because that's the sexy new thing not new, but the great thing in anesthesia now, multimodal everything. Okay, so after the acute pain series, we'll move on to regional and anesthesia. So we'll talk about like the different most commonly used blocks, as well as the facts that are relevant to boards, and we'll also talk a lot about neuroaxial procedures and the pharmacology, physiology behind those as well. So lots of stuff to look forward to. I'm hoping to pump out these episodes, or at least record them this week before I move on to my next set of difficult rotations. So so with all of that said, let's kind of talk about what we're going to discuss during this particular episode. So again, this is the episode on anatomy and physiology pain signaling. So first, we're going to talk about somatosensation, nociception, and pain. Like, what do those things mean? And the process in which a stimuli is registered as pain in the body. We're going to talk about the peripheral mechanisms of pain sensation. So the different neurons, types of neurons that send pain signals. So this is going to be important for you to know for boards for sure. Next, we're going to kind of move on towards the central nervous system. So the spinal mechanisms of pain processing. And then from there, we're going to go up to the brain and talk about the supraspinal mechanisms of pain signaling. Then it's going to be a little bit of neuroanatomy involved for this as well. I'll try to keep it as painless as possible. I remember in med school, this was not my favorite subject, so I'll try to make it a little bit more enjoyable for you during this episode. Okay, that was a pretty long introduction, so with all that said, again, let's go ahead and get started. All right, so in this first section, we're going to talk about somatosensation, nociception, and pain. So we're going to first talk about the different definitions of these three things. So one by one, this somatosensation is defined as a process in which neurohormones activates a physical stimuli to cause perception of touch, pressure, and pain. So basically, the process in which the outside world causes a stimuli and then it is registered as a neurochemical signaling in the central nervous system, basically. Okay, so that's somatosensation. So physical world interacting with the inside of the body. Okay, nociception. Nociception is the physiologic process of activation of neural pathways by stimuli that potentially or actually damages tissues. Basically, nociception is the stimuli that can actually cause damage, and it's because traditionally associated with pain. So, say for example, you get punched or you get stabbed or something like that. So those things could damage tissues, and that stimuli is translated into neural pathways to register it as pain. Hopefully that makes sense. And then lastly, something to define is suffering. So suffering is multifactorial, and basically this is the perception of the pain. So again, suffering could result in, or could be caused by a loss of physical function of like limb or something like that. It could cause social isolation, family distress, sense of inadequacy, or spiritual loss. So again, it's like the psychological perception of the pain. So again, somatosensation is just some sort of stimuli from the outside world, touch, pressure, and possibly pain that's not necessarily damaging to tissues. So somatosensation, nociception is similar in that it's stimuli from the outside world, but the physical stimuli could be damaging to the tissues and causes the pain. And lastly, suffering is the psychological response to the pain. Next is the sequence of pain signaling. So generally for pain signaling, there's 4 major steps. So one by one is transduction, leading to transmission, leading to modulation, and lastly, the perception of the pain. So again, we're going to go through these one by one. So first step is going to be transduction. And this occurs in the peripheral terminals of the primary afferent neurons. And the stimuli is going to be enough to induce an action potential. So the stimuli, whether it be mechanical stimuli, heat, chemical, or cold, that's is enough to cause an action potential and start the pain signaling process. So this is transduction. So next is transmission, and the transmission portion has 3 major components going from original stimuli all the way up to registering in the cortical structures. So first, from the periphery, the action potential is going to lead all the way up to the cell bodies of the peripheral sensory neurons in the dorsal root ganglion. And from there, it's going to go to the spinal cord and going to have the terminal synapse of the second order neurons in the spinal cord. So that's the first component. Second component is the spinal neurons. So from the spinal neurons, it's going to project all the way up to the thalamus and other brainstem structures. So this is like pretty much the intermediary portion from the spinal cord going to the midbrain, the brainstem structures. And lastly, in the third component is going to be the cortical structures. So to review, basically 3 major components. The first one is from the peripheral neurons going to the dorsal root ganglion, which also synapses in the spinal cord. Then from there, the second part is the spinal neurons projecting from the spinal cord all the way up to the thalamus and brainstem structures. And lastly, the third part is going to the cortical structures. Okay, so that's transmission. Next is going to be modulation. So basically, this is when neuroactivity is altered throughout the transmission process. And the major site of modulation is going to be the dorsal horn of the spinal cord. So basically, you're going to the gateway of like signaling. So basically, it's going to try to determine which signals from the outside world is going to be sent up to the brain, essentially. So that's modulation. And lastly, perception is the last part, where the neuroactivity results in the sensation of pain. So again, this is when you a higher order of cognition to perceive the pain. So again, perception. So from the top, transduction. This is the stimuli that causes the action potentials. Transmission is going from the outside world to the three major components. So first section is going to dorsal root ganglion and to the spinal cord. Second portion goes to the spinal neurons, goes up to the brainstem and thalamus. And third part is going to be the cortical structures. Next is going to be modulation. And this is basically altering transmission of pain signals. And the major site for this is dorsal horn of the spinal cord. And lastly, perception is the sensation of pain. Okay, so we're going to pretty much travel from the outside, from the stimuli, all the way up to the brain. We kind of go through these steps. So, and then we'll try to highlight any high yield points. Okay, so the first one's the peripheral mechanisms. So basically, from the stimuli going to the primary afferent neurons, the action potential is going to be sent all the way to the cell bodies in the dorsal root ganglion, in which there's three major classes of nerve types. And basically, it's kind of categorized by its myelination as well as the diameter of the neuron. Okay, so these three major classes that you will have to know are: one is the A beta fibers, two is A delta, and lastly, the C fibers. So for A beta fibers, this is going to be the fastest of the three classes that we just mentioned, and it's going to be greater than 20 meters per second. So that's pretty darn fast. And A beta is a large diameter neuron, and it is myelinated. So that's why it's able to conduct such fast speed. And this is going to be activated by light touch, pressure, and hair movement. So again, A beta is the fastest one. The way I remember it is beta it's better than the other ones because it's not a lot faster. So A beta is large diameter, myelinated, very fast. Next is A delta. And this one is kind of like a medium range one. So it's like 2 to 20 meters per second, depending on, which one you're evoking and, or the one that you're using. And lastly, this one evokes the sharp and intense tingling sensation that patients could feel. So like the neuralgias, paresthesias, that kind of thing. Okay, so that's A delta. That's in the middle. And lastly, C-type fibers is the slowest one. So it's less than 2 meters per second. And this is actually going to be the dominant type of peripheral nerves. So it's going to be 75% of the peripheral nerves. And this one is going to be associated with prolonged burning sensation. So again, to review, three classes: A beta is the fastest one, large diameter, myelinated, activated by light touch and pressure. A delta, the middle one, 2 to 20 meters per second. It's the sharp, intense tingling sensations. And type C fibers are the slowest one, not myelinated, very small fibers. And it's associated with prolonged burning sensations. All right, and before we move on from peripheral mechanisms, we're going to mention that these fibers could be activated, multiple types of these fibers can be activated at once. So this is called dual activation. And a good example of dual activation is going to be heat. So for example, when a patient is exposed to heat, say they grab a hot stove or a hot pan or whatever, the first pain sensation is actually going to be the A delta fibers. It's going to be the prickling sensation that they feel. And then from there, you're going to have a slower onset C fibers to really feel the burning pain. So I don't know if you ever been burned before. I've was pretty dumb and I grabbed something very hot without thinking once, and this is pretty much it. The first pain sensation you're going to feel is really hot, prickling, and that's going to cause you kind of to withdraw from the sensation. But after like a few minutes or so, the creeping burning pain starts coming up, and that's going to be the C fibers. Okay. So again, like, there's always going to be, or not always, but, there's a possibility of dual activation for different types of fibers working together. And, these, fibers that transmit information to the, central nervous system. And it kind of gives, information about the intensity of the pain, the location, and the duration of the, noxious stimuli. Okay. So that's the peripheral mechanisms. Okay, next is going to be the spinal mechanism. So we're going to move on up from those fibers into the spinal cord. So the most important part of the spinal cord, I guess in terms of sensation and pain signaling, is going to be the spinal dorsal horn or the dorsal column nuclei. So it's going to be the first synapse in the somatosensory processing at the spinal dorsal horn. And just because I just thought of it as something that you'll see in IT, basic, whatever. So, because this is where a lot of the pain simulation enters to be sent out the spinal cord, this is actually where spinal opioids, like intrathecal opioids, acts to reduce pain. But that's going to be in a later episode. It's just something that I just remembered. So again, dorsal horn of the spinal cord is going to be very, very, very important in terms of receiving pain stimulation. Okay, again, once the action potential reaches the spinal dorsal horn, it's going to be sent up to along the spinal cord to the midbrain area in either the spinal trigeminal nucleus or the chief sensory nucleus of the trigeminal in the mid-pons region. So from the outside, neurons, the afferent neurons going to the spinal cord goes all the way up to the midbrain, basically. Okay, so it's basically, yeah, okay. So the interesting thing is that dorsal horn is actually broken up into 7 layers or seven laminae, or like the Rex lamina or something like that. So if you hear that, it's basically the different layers of the dorsal horn. And the interesting thing is like the different types of peripheral fibers, like the A delta, A beta, C fibers, they actually terminate in different levels, different layers of the dorsal horn. So for example, the C fibers will terminate in the superficial lamina, so in layers 1 to 2. And I guess we'll take a quick step back. The layers from superficial to deep is 1 through 7. So 1 being the most superficial, and 7 is going to be the deepest layer of the dorsal horn. So again, for C fibers, it's going to terminate in the superficial lamina in 1 and 2. Lamina 1 is going to be correlated with the marginal nucleus, and lamina 2 is going to be the substantia gelatinosa of Rolando. Okay, so that's C fibers, most superficial 1 and 2 lamina of the dorsal horn. Next, we're talking about the A delta fibers, and these ones going to end in lamina 1 and from lamina 3 to 5. Okay, and lastly, A beta fibers is also going to terminate in laminas 3 to 5 as well. Okay. So if you would want a picture to kind of look at, I would encourage you to take a look at the show notes or in the book that I'm using for as a source, like Benson Essentials of Pain Medicine, 2017. This is in chapter 1, and or otherwise you can always just Google it or something. Okay, so that's like the dorsal horn. Again, from the peripheral, it's going to terminate in the dorsal horn, and there's the different lamina. And this isn't something that you'll generally see on boards because I feel like it's a little bit too in-depth for like ITE or basic or something like that. It might just appear in pain medicine boards. But just for completeness, we're going to just talk about the second order nociceptive spinal and spinal trigeminal projection neurons. So if you don't want to learn too in-depth stuff, you might want to skip ahead a little bit. I should have timestamps in the description. Okay, so moving on. So this the second order nociceptive spinal and spinal trigeminal projection neurons. There's two main ones that we're going to talk about: the wide dynamic range, or WDR, and the nociceptive specific neurons. So the WDR neurons is concentrated in a deeper lamina. So lamina is 3 to 5. And it receives info from the A beta, A delta, and C fibers, so pretty much the major peripheral neurons for noxious stimuli. And it's interesting because it has what's called graded responses. So then it basically, the more noxious the stimuli, the more response that these neurons will invoke. So it responds more to noxious stimuli versus non-noxious. And why is this important? Honestly, I am not completely sure. Sorry. But basically, it's just be aware that these things exist, the wide dynamic range neurons, and it receives info from all sorts of those fibers, A beta, A delta, and C fibers, and it's a graded response. Okay, so that's WDR. Lastly, the nociceptive specific neurons, and these ones, as the name suggests, respond to only noxious stimuli, and these are found in laminas 1 and outer layer of 2. Okay, so that is the spinal mechanisms. Next, we're going to briefly talk about spinal modulation. The most important thing that we'll probably talk about regarding spinal modulation is going to be gate control theory. You probably already know about this or indirectly applied this in your daily life. So, for example, have you ever, say, gotten punched by someone, or got hit, or kicked a nightstand and stubbed your toe, or you stepped on like a Lego brick or something in the middle of the night? Or when you were a kid, did you have one of those razor scooters and you accidentally swung that bad boy into your ankle, and then it hurts a lot, right? So what do you do afterwards? You basically kind of sat there, cried a little bit, and then you rubbed that area, right? So you're actually applying gate control theory. So basically the idea is you're at the site of noxious stimuli, you're just going to stimulate that site even more by rubbing it, and then over time, that's going to desensitize that area to pain. So that's kind of why you kind of rub the area that kind of hurts, right? And this also explains the TENS unit that could be used for pain. It's basically something that you can use in like physical therapy. You can actually buy it on Amazon. You can slap on electrodes, and then it kind of just vibrates or sends impulses at that area, and that is supposed to help relieve pain. Okay, so again, this is a more practical usage of gate control theory. The more nitty-gritty details is basically the input along A beta fibers inhibits the WDR cells to nociceptive input. So basically, the continued repeated stimuli goes along the A beta fibers after the initial insult, and that's going to inhibit the WDR neurons that we kind of discussed earlier, assuming you didn't skip that portion. Okay, so that's gate control theory. Next one is going to be, we're going to talk about different types of neurohormones that's associated with excitatory and inhibitory messages along the spine, and it's important for spinal modulation. So first off, the most important excitatory neurohormones is going to be glutamate epinephrine, and norepinephrine. And the most important inhibitory neurohormones is going to be GABA, glycine, and serotonin. Okay, so that's neurohormones regarding excitatory and inhibitory systems. The other concept in spinal modulation is going to be central sensitization. And this is the capacity of for transmission in a nociceptive system is changed or shows neuronal plasticity. So an example of central sensitization, and it's something that showed up in one of my True Learn questions, is going to be the concept of wind-up. So basically, the repeated stimulation of things like C fibers causes increased pain of the same stimulation. So an example was if you had a rubber band and you kind of pull it back and let it snap onto your skin, and you keep doing that over and over again. Like the initial insult was painful, but the more you do it, it actually gets even more painful. So that's the concept of wind up. And that's, in I guess a board question is going to be, it's distinguishing wind up versus something like hyperalgesia, which is going to be excessive pain from some sort of stimuli, but the difference is wind up is the same pain that occurs, and it increases in intensity over time. Okay, and lastly, regarding spinal modulation is going to be the different modulation effects from glial cells. So different things that you might remember from med school or whatever, the microglia, astrocytes, and oligodendrocytes. Basically, after receiving some sort of nerve injury, these glial cells would release cytokines, inflammatory mediators, growth factors, and all that good stuff, making the inflammatory soup, and that's going to affect the neuronal function. And lastly, this is kind of going a very deep dive that's not commonly seen in boards, at least I haven't seen it, is the microglia actually releases something called brain-derived neurotrophic factor, so BDNF, which downregulates potassium channels, which causes a shift in anion gradient, and the normally inhibitory input eventually becomes excitatory. So basically, the key points to understand from this is not all information that's received from the outside world goes all the way up to the brain for processing, right? So that some things are going to be amplified, some things are going to be muted or downplayed. I forgot the word; it's not coming to me. So there's going to be like the interaction between excitatory signals and inhibitory signals to determine what actually eventually gets up to the higher levels of the CNS. And again, not too board relevant, it's just nitty-gritty details, but microglia also has a role to play in terms of modulation due to cytokine inflammatory mediators and also the brain-derived neurotrophic factor. Okay, next is the supraspinal mechanisms, and this is going to be, we're moving on up towards the brain. So the primary structures that's involved in supraspinal mechanisms is going to be the brainstem, the diencephalic structures, and the cortical sites. And in order to get all the way up to the brain, there's two main ascending pathways. The first one being the anterolateral spinal thalamic tract, and the second being the dorsal column medial lemniscus. So we'll kind of talk about these two things one by one. And again, I encourage you to take a look at the show notes so you can see pictures, or you can Google it yourself. Okay, so the first one, anterolateral spinal thalamic tract, is the primary pain signaling tract going from the spinal cord all the way up into the brain. Okay, first of all, the primary pain signaling received by the anterior spinal thalamic tract is going to be the crude touch and pressure along the anterior portion, and the lateral portion is going to sense the temperature and pain. So one thing to note about the anterior lateral spinal thalamic tract is that the pain signals is going to cross at the level of the spinal cord. So the same level in which they experience the insult. And then from there, it's going to go straight up into the brain. So for example, if you get a pinprick on the left side of your arm, it's going to cross at the level of the spinal cord. And it's going all the way up to the right side of your brain. Okay, so that's the anterolateral spinothalamic tract. And I guess in terms of, for completeness sake, we'll kind of talk about the different orders of neurons in terms of this tract. So first, second, and third order neurons. First order neurons is going to be from the outside world into the dorsal root ganglion, and that terminates over in the dorsal horn. So that's first order neurons. And then from there, it's going to synapse into the second order neurons in the substantia gelatinosa, and it's going to cross over and then go all the way up into the midbrain. So that entire part is going to be a second order. And the third order neurons is going to be from the midbrain to the cortical sites. Okay, so that logistic stuff out of the way. Once the second order neurons synapses into the midbrain, it has various effects. So once the second order neurons synapses into the brainstem, it influences cardiovascular and respiratory functions. If it synapses into the midbrain, it has multiple inputs for both. It modulates the inputs from descending and ascending inputs. And lastly, when it synapses into like the diencephalic structure, so things like the hypothalamus, and the thalamus, is going to affect things like temperature regulation and all that good stuff. And so hopefully that made sense. Again, anterolateral spinothalamic tract is responsible for crude touch and pressure on anterior tract side, and the lateral side does temperature and pain. Okay, and the second one is going to be dorsal column medial lemniscus, and this one is responsible for fine touch, vibration, 2-point discrimination, and proprioception of skin and joints. This is relatively high speed and has discrete signaling channel for innocuous stimuli. So regarding the DCML, we'll talk about the different orders of neurons. So the first order is going to go from the limbs, and it's going to go ipsilaterally along the limbs to the ipsilateral dorsal horn. And it's going to all the way up until it gets to the nucleus gracilis and the nucleus cuneatus, and that's where it's going to cross over to the other side and synapse into the second order neurons. So from there, it's going to go up to the contralateral corticocytes and via the third order neurons. Okay, so again, the two main ascending tracts, the anterolateral spinothalamic tract, which is responsible for crude touch, pressure, temperature, and pain, and the dorsal column medial lemniscus, which is responsible for fine touch, vibration, 2-point discrimination, and proprioception of skin and joints. Okay, so those two tracks aside, the last thing we're going to talk about regarding supraspinal mechanisms is going to be the pain matrix. And what is the pain matrix? So basically, it's like different sites of the brain that is involved with pain. So the implicated brain regions includes 5 major areas. So the first one is going to be primary, secondary somatosensory cortices, the insula, the anterior cingulate cortex, the prefrontal cortex, and several of the nuclei of the thalamus. And why this is important is because the analgesics that we give appears to affect different regions of the pain matrix. So there's 2 different pathways that could be involved. So the lateral and medial pathway. The lateral pathway encodes sensory discriminative aspects of pain perception, and the medial pathway is involved in affective component of pain reception. So basically, the medial pathway is required to encode the unpleasant and aversive aspects to pain. So this is like the perception portion of pain signaling. So an interesting example of this perceptions to pain or lack thereof is in patients that have unilateral ischemic changes to the insulator cortex, causes something called asymbolia. I'm not sure how to pronounce that. But basically, it results in a lack of inappropriate emotional response to multiple painful stimuli. So it's more than a kink. It's just an actual inability to have appropriate response, emotional response to painful stimuli. So yes, that's the medial pathway, and it's involved of pain perception. Okay, so that just about does it in terms of the anatomy and physiology of pain signaling. Just for review, since this right now I am at the 45-minute marker before editing, we're just going to go over key points for you to take away from this episode, and hopefully you're not completely confused. So again, from the top, the main points of pain signals or pain signaling is going to be transduction, transmission, modulation, and perception. So the peripheral nociceptors are going to respond to different noxious stimuli, includes things like intense heat, cold, mechanical, or chemical stimuli, and they work together to encode the intensity, location, and duration of the stimuli. Next, the dorsal horn is anatomically organized into the different rex laminae. The important ones to remember are the unmyelinated C fibers end in laminae 1 and 2, and the large myelinated fibers end in laminae 3 to 5. Next, the two types of second order nociceptive spinal and spinal trigeminal projection neurons are the wide dynamic range neurons, or WDR, receives input from A beta nociceptive, C and A delta fibers, and the other one to know is the nociceptive specific neurons, or NS. Next, the somatosensory system is made of two main signaling channels. So the two ascending tracts, the anterolateral system, which is the primary one, and that's associated with crude touch and pressure, as well as temperature and pain. And the other ascending tract is the dorsal column medial lemniscus, and that's associated with fine touch, vibration, 2-point discrimination, and proprioception of skin and joints. And lastly, regarding the different types of areas that's involved with pain matrix, the cortical regions associated acute and chronic pain are the primary and secondary somatosensory cortices, the insula, anterior cingulate cortex, the prefrontal cortex, the amygdala, and the various nuclei of the thalamus. Okay, so that's about it for this episode. Hopefully you got something out of it. Hopefully it wasn't too confusing for you. If you are confused, I would encourage you to take a look at the show notes. It might make a little bit more sense. If not, my bad, but you made it to the end of the episode, so thank you for, at the very least, listening to me talk in a bunch of nonsense. If you motivated and you actually think this episode is, or this podcast in general has helped you out, I would highly encourage you to leave a rating on Spotify. It doesn't really help me. I'm not getting any money out of this. It just makes me feel a little bit better about myself. If you would like to leave comments in the Spotify, I think you're able to do that on Spotify now about the different episodes. I would encourage you to do that, or you can always contact me via email or my Facebook page. I'll eventually get better about other social media stuff, but I am very bad at that. Okay, before I end this, basically I just want to give credit where credit is due. The main source for this episode, in terms of where I got this information from, is from Benson's Essentials of Pain Medicine. This is the 4th edition. This particular information was from Chapter 1. And all of the information, again, credit to them and the authors. The script and narration is provided by me, and opening music is from Brian Tew. So again, thank you very much for listening to this episode. I hope you got something out of it, and I hope to see you in the next episode.